Okay, good afternoon everybody and welcome to the Global Digital Exemplars GS1 Standards in Healthcare, the importance of aligning the two programmes. I am Monica France and I work as part of the GDE Learning Network team at Ardenham Gen CSU. I'm delighted to be introducing to you today Juliet New from GS1 UK and from Luton and Dunstable University Trust, Philippa Graves, CCIO and SRO for the GDE programme, and Sandy Bunyan, Procurement Manager for GDE and GS1. They will be talking us through the webinar, and so we have allowed time for questions at the end. Please feel free to submit these to us using the host, Katie Wardle, using the chat function, and you should be able to access that on your screen. You can send questions to us if there's any problems through a private message to Katie Wardle, the host, but please use that function to send questions to the presenters, which we will read out for you at the end. So I would now like to hand over to Juliet, Philippa and Sandy to take us through the presentation.
Great, thank you, Monica. Good afternoon, everybody. I'd just like to thank you very much for taking the time to join us on this webinar. My name is Juliet New and I'm an engagement manager at GS1 UK. We're going to be talking about GS1 and the Global Digital Exemplar programme, and the agenda for today's session is going to cover an overview of GS1 in healthcare. We're going to look at why alignment is so very important and what are the benefits that the Trust see as a joint approach, and also what are the challenges that the Trust as a Luton are going to see or need to overcome, and then cover off what their timescales are going to be for the GDE programme over the next few years. So who are GS1? So for those of you who don't know, GS1 UK is a not-for-profit membership organisation, and we're working with the healthcare industry to set standards which actually help improve business efficiencies and reduce costs within the healthcare sector. We're one of 112 GS1 member organisations across 150 countries, and we operate in multiple sectors and industries such as retail and food services. So for over 40 years, GS1 UK has been driving great efficiency in the movement of goods and the sharing of information. The adoption of GS1 standards allows for the unique identification of every person, every product, and every place across the NHS. So in healthcare, we help the NHS save thousands of lives and millions of pounds. The way that we're actually doing this is by working with our healthcare providers and suppliers to help improve patient safety, reduce clinical variation, and deliver greater operational efficiencies. So what is the GS1 system? Well, there are three elements to the GS1 system, and they are identify, capture, and share. GS1 standards provide the foundation of integrated patient care in the NHS by enabling the globally unique identification of every person and every product and every place. And you're going to hear those three elements throughout this whole presentation. The GS1 keys that are used are non-significant. They are secure and globally unique numbers which support the identification of every item, every case, a pallet, be it a location, a logistics unit, or even a returnable container. It's all about connecting the flow of goods and the sharing of information. And so to help capture this information, we use a variety of barcodes and RFID tags, as they are the carriers for these identifiers in a machine-readable format. Then we have the third element, the share, and the global data synchronization enables data consistency and accuracy through exchange of identifiers and standardization and standardized product information via national and global data pools, helping the variety of systems that are used within the NHS to be interoperable. So what I'm going to do now is just show you a short video on how GS1 touches all aspects of the patient pathway, and will actually give and explain it a lot more simply than I could. So I'm hoping this is going to work.
We're making a huge difference in healthcare, saving the health service thousands of lives and millions of pounds by implementing GS1 standards. It's simple. By using unique identification numbers, it's possible to identify every person, every product, and every place. So hospitals can identify every item and patient interaction from beginning to end, from taking delivery of an order to treatment at the bedside, and beyond to aftercare and the sterilisation of surgical equipment. Let's follow one patient through their visit to a hospital to see exactly how GS1 standards are used to increase patient safety and efficiency. This is Laura. She needs a hip replacement. She goes to a local hospital for her scheduled operation. A nurse welcomes Laura and gives her a patient wristband. The nurse also performs a medical examination which shows that Laura's blood pressure is too high. When the nurse scans the GS1 barcode on Laura's wristband, this information is automatically updated to her patient record shown on the screen. The doctor also updates her patient record with the diagnosis. He also prescribes medication and a standard surgical package for the hip operation. The nurse checks the prescription on Laura's patient record to make sure she selects the right medication and the right dose. The nurse also scans the barcode on her own identification card and then scans the barcode on the medication. Because of GS1 standards, there's no need for manual data entry in several different systems, eliminating human error and increasing patient safety. A unique number is allocated for each product, which then makes up a barcode and is linked to data in a central database. The barcode can be scanned at every point of the supply chain, from manufacturer to treating the patient, which enables complete traceability. Before the surgery, the nurse scans Laura's patient wristband and the medication to make sure Laura is given the right treatment. And this is automatically updated onto her patient record. Thanks to this simple procedure, everyone with access to Laura's patient record can see what treatment she has received, at what time, and who dispensed it. Before Laura's hip surgery, the nurse collects the correct surgical package for the operation. When she scans the barcode on the package, the inventory management system automatically records one less in stock. Using barcodes enables you to better manage inventory from a central database, making it possible to control batch numbers and expiry dates. Now, Laura is ready for surgery. Her patient wristband is scanned in the operating theatre and the correct hip implant is retrieved from stock. One of the surgical procedures is to scan the barcode on the implant packaging. The barcode contains important information, including a serial number which is recorded on the patient record. This makes it possible to link a specific implant to a specific patient, increasing patient safety. It also means tracking the product is easy, especially in the case of safety recall, by using GS1 standards. Before leaving the hospital, all the information about Laura's visit is recorded, including a prescription following her successful surgery, which is updated onto her patient record. The pharmacy can access this information on the prescription server, so the medicine is ready for Laura to pick up. At the pharmacy, the pharmacist scans the barcode on the product. The batch number and expiry date of the drug are automatically checked before the drug is given to Laura. A unique number and an individual serial number make it possible to automatically control the product to detect counterfeit products and manage safety recalls. There is a huge amount of information needed in just one patient process. GS1 standards make life easier for everyone by providing a single way of identifying every person, every product, and every place. GS1 standards, saving the health service thousands of lives and millions of pounds.
So hopefully that gives you a good insight to see how GS1 standards work along the patient pathway. So GS1 works with a variety of global organisations such as ISO and HL7, and we work with these organisations to ensure that we do not create additional standards, but to use the standards already created appropriately and to ensure we don't duplicate effort. They are very much driven by our members, for our members. So typically, GS1 standards are ISO, and GS1 incorporates them into a more simple focus area. So for instance, if we look at EPCIS, this is a global GS1 standard that creates and shares visibility of event data both within and across enterprises to enable the user to gain and share view of physical or digital objects within a relevant business context. So this EPCIS standard has been put through the ISO process. So for many years, we have been working with the NHS and the Department of Health and Social Care to bring similar sorts of efficiencies and benefits to the healthcare sector that the retail sector has benefited for many years. Back in 2014, the Department of Health mandated the use of GS1 and PEPL standards throughout the healthcare sector and its supporting supply chains. And every healthcare provider and every supplier of every product and service into the NHS must comply with GS1 standards by 2020. The GS1 standard is very much integral to the Carter Review, the Personalised Healthcare 2020 and the NHS 5-year forward view. It very much sets out a framework to enable England to become a global leader in the provision of digital health and care services that help improve patient safety and transparency. So what our standards do is provide you with the common language to be able to track and trace all the way through the patient pathway, be it your patients, be it the medicines, or be it products. So there are 6 NHS trusts that were fully funded for the early adoption of GS1 standards, covering a range of trust sizes, services offered, and complexity of the patients treated. The Department of Health and Social Care made funding available to these demonstrator sites to fast-track the full adoption of GS1 standards across the whole of each of their chosen trusts. And what these trusts have done is provide insight into the practical challenges and opportunities of adopting GS1 standards in a live healthcare environment and provide an invaluable measure of objective metrics. They will provide a true validation of how GS1 standards work in a hospital setting with actual real costs and benefits that can be achieved. And one of the major outputs of the demonstrator site activity will be to provide clear guidance and best practice for each of the other NHS trusts. So what are the core enablers? These are a number of GS1 keys that need to be adopted by both the trust and their suppliers to ensure GS1 and PEPL adoption is consistent with the standards. These are known as core enablers. So to help identify a person, we have a Global Service Relationship Number, or a GSRN. To help identify a product within a trust, we have a Global Trade Item Number, a GTIN. And we have the ability to identify a place, a location number, which is also known as a GLN. So what these keys do is enable unique barcodes to be created that provide access to electronic data sets, providing trust and suppliers with the ability to retrieve data attributes associated with a barcode by simply scanning the barcode. So what I'm now going to do is show you another video, and this second video is basically from your peers, and what it will do is show you how GS1 standards is actually benefiting their individual trusts.
Using GS1 standards to scan every person, every product and every place means that we can free up our nursing staff to do what they do best, that's look after their patients.
We use RFID track and trace technology to help manage our health records. This has many benefits to patients, increasing safety by ensuring our health records are available to clinicians when and where they're needed.
All the products in our catalogue are identified using GS1 standards. This covers over 200,000 items. Our order process is more streamlined. We're able to track and trace over 1 million deliveries to their final location. This data is key for complying with UDI legislation and, most importantly, it's safer for patients.
Well, we literally scan every procedure that we undertake in theatre. And so far, we've recorded data from around 100,000 procedures, which is very, very useful in terms of patient safety. Because whereas in the past, if I had a product recall issue, it would take about 50 hours to trace and track. Now we can do it electronically within 30 minutes. And for me as a clinical director, it's really important that I can look at clinical variation so that I can see differences in consultant practice.
The data I get from GS1 standards gives me the management information I need to run my hospital. As a result, we've integrated our inventory management, product catalogue and financial systems, creating the ability to identify efficiencies that will save us over £3 million this year. This is just from the information of our rollout in theatres, radiology, endoscopy and cardio cath labs. In addition, as everything is recorded against the patient, we also get accurate patient-level costing.
My team and I are ready to start scanning GS1 barcodes to uniquely identify every product that passes through the site. This will give me the assurance that medicines can be authenticated across the supply chain. We will also scan medicines again before dispensing for eliminating errors and making it safer for our patients. And it will keep us compliant with the regulations, including the Falsified Medicines Directive.
I'm really proud that our trust is at the forefront of implementing the GS1 standards. It's helping us in lots of ways to improve patient safety, to reduce unwarranted clinical variation, and to make us more efficient. It's also supporting me and my team to make the best possible decisions to deliver great care for our patients today and tomorrow.
So hopefully that video gives you a flavour of what the benefits are of GS1 standards in a variety of hospitals. So that concludes the overview of GS1 standards in healthcare, and what I'd like to do now is pass the baton over to Philippa, Philippa Graves is the Chief Information Officer, and Sandy Bunyan, the Procurement Manager for the GDE and GS1 at Luton and Dunstable University Hospital.
Thank you very much. So just to say a bit about our trust, we are a best of breed trust, so we don't have one EPR, it's an integrated EPR. And we have been adopting lots of technology and trying to get improvements, improve patient safety, etc. With our clinical teams, we work very closely together. And GS1 is making up one of our work streams, and hopefully our vision is to try and use it across the whole trust. Now, I guess the challenge for all of us in healthcare is lack of standardisation. Where would I start? I've got all this already in my trust, is it compatible? So I think that's the major challenge, and we are breaking that down into bite-sized chunks so we can complete the journey in a manageable way. You can't rip everything out and replace it, and you don't need to. So we've been trying to do as much fact-finding. It's a new arena, and that's why Sandy is so important. The challenges that we face doing this are there isn't one product that fits all. There isn't necessarily one handheld scanner, one barcode printer. So we're trying to break it down into individual components. We have mapped our whole patient pathway for GDE. It's going across a massive wall, and every component's being looked at. So we saw on the video the bed level. For us, patients don't always get back into the same bed frame because we're so hyperdynamic. So the bed spaces is important, and the patient, and all of those variables, but we're mapping it out. We already have blood tracking. We use Bloodhound. We have handheld devices with barcode readers, but we're trying to see how we can have technology that's universal across the patient pathway. One of the challenges when you already have things in place is someone will give you a new product and a new functionality that requires a whole new level of hardware. And that just can't happen because our nurses already have tool belts, and we're trying to work our way through to have standardisation. So GDE and GS1 for us are integral, and although we're not an early adopter site, we're trying to do a really well-directed pilot. We have a lot of clinical engagement, we have technical engagement, we have procurement engagement to try and come up with a proof of concept that shows to our trust that this is the right thing to do. And we have an awful lot of change going on. We have the same pressures that everyone does. The front door is heaving, the back door is as busy as ever. And within all of that, we're now trying to bring in new technology. But because of all of the benefits, because of the safer practice that we'll be able to deliver, we have full board support. And I think I think it's really important to say that Andy has done a brilliant job in getting a director to take the gauntlet up and to champion this for us. I sit on the board and I bring it into the room, and we go to all of the clinical divisions and we make it real for people. So I think the most important thing is that it's doable no matter who you are or where you start. And we found with everything that we approach in the trust, and it's a medium-sized district general, it's not a massive, great big teaching hospital, but the challenges are the same and implementing technology is the same. And even though you have a large digital maturity, ours is 5, doesn't make it any easier because you've already got so much in place. So the hope is that by following our well-tried and tested, clinically led pilot, evaluate, recheck, then try again, every area in the trust is different. I see it as kind of the world, and you need to speak a different language and implement things differently in maternity than you do in surgery, than you do in medicine, even though the product is fundamentally the same. We get experts from those areas involved. And the overall output, we hope, for our GDE colleagues and for the whole of the NHS is a blueprint that you'll be able to pick up and say, look, this is what they did with that, this is how they chose the product, this is how they integrated it, this is how they trained it, this is how they delivered it, evaluated it, and then got the benefits case at the end. Because no matter what you do, even if you get early adopter money, to do it across the whole trust in every area will be an ongoing project. It's a marathon, really, not a sprint. And so we're trying to put that in place to do proof of concept. Next slide, please. So it's so important. It's all one, as I said, it's a program. All of our teams work on all the elements. We took our whole portfolio and we looked for areas that we had gaps or we could improve, or in this case, new technology to make it more efficient. And we've been learning from others. So we've been to the sites that have been listed on the slide, and we have been so grateful to the amount of learning and opportunities that we've been offered, learning from others. We are not a large trust, as I've just said, and everything we've done has always been cost effective. When we did an analysis of what it costs to run the trust IT platforms versus what other industries cost and other NHS trusts, it was at the very lower percentile, but the quality was high. And that is about working with suppliers and getting standardization and using what you already have and clinical adoption. And we'd like to think that we'll continue that mantra throughout this project, because success is value for money. And if it costs millions and millions of pounds, even if you deliver great things, it then makes your trust board think, well, really, should we be investing in this when that's an ITU bed for a week, a month, or a year? So everything matters. It also has to be resilient. No matter how fantastic things are, when they go down, your clinical teams are left bereft. They're using it to track a patient. Suddenly you can't track anymore. Most of our patients are tracked now to bed level and to procedure level, and we can do that with our current systems. And when we've been doing upgrades, patching, we have very little downtime, but when it happens for planned reasons, it is really difficult to keep the quality up and keep your eye on the patient pathway. So it matters that whatever we build is resilient and that it doesn't cost millions in maintenance from suppliers. So working with them and having a cost-efficient solution is really important. And as I said, we have partnered with everyone. We found the GDE platform and all of the partners that we've gained and then already had in terms of suppliers, companies, tech companies. We've been working with Apple. We have a lot of hardware, but we've also got Android devices now. So we're trying to have a portfolio that fits all needs and integrate those together. And it has been a really big opportunity. Sandy and the team have done brilliant work with working with new suppliers in the field to fill this gap. But my mantra has always been it has to work with everything. We will not have 6 devices to track a patient. We will have 1. And we will not be inventing new printing opportunities because the cost of that is huge. It must work on existing platforms. So those are the kind of the guidelines that we've been working to. And we've seen this as a really big opportunity, and so far I'm pleased to report we haven't found any hurdles that we aren't managing to overcome. Next slide, please. So the joint approach, the benefits, yeah, absolutely. Duplication, I see it everywhere. You will find suppliers, everybody's going into the same field. One system does the same as another system, and which system do you choose as your one version of the truth? And where do things start and end? And that's come back to our patient pathway and having everybody able to come and challenge it. We've had loads of drop-in sessions. We go and place ourselves up in the canteen where we have a large footfall, and we try to get views of all of our customers as well as patients and carers, because it matters that this works across the whole health economy. And being also linked to the SDP, I'm on the SDP digitisation board, everything we're doing will be fit for purpose across our whole patient pathway, and our patients are owned by many different healthcare providers. Everything we do must not disrupt BAU. As I've just said, we are really, really busy, 30% busier than this time last year at the moment, especially with medical admissions. So we cannot put any more pressure on our workplace, trying things out and just being in the way. It has to be completely congruent with the business as usual agenda. Value for money as a trust of this size, our operating surplus and our value for money figures, we have to keep within those. And we have a very close working relationship with finance, and they are a really big supporter of this. Our Director of Finance has given it his endorsement, and that really makes it a really interesting paradigm to have endorsement because of the cost efficiencies that we make. We're not trying to save money, we're trying to deliver better care with the same money that we spend. The blueprinting opportunity, everything we do, we're happy to share, and other sites that are best of breed and don't have one base EPR, we're hoping to have overcome a lot of the hurdles that other people will face so they can learn from us and not have to reinvent the wheel. The timing in our programme, we're trying to make it fit when we're coming to roll out. It is fitting at the moment within our e-pharmacy work stream, but we would really welcome the opportunity to roll it out to theatres as they have in Derby, because we see so many benefits and wins. And our CSSD department would really welcome that in terms of being able to match all the equipment, etc., to the patient episode. Although we do have barcoding, they're not linked in the same system. We have been learning from others. There is such a wealth of knowledge out there, and so many people are so willing to share. And it just requires you to ask. Sometimes you think, oh, well, they won't have time for me, or they won't welcome us, but they've always been so welcoming. Mistakes, I think the one thing I would say is people don't ever tell you about what went wrong. In our blueprinting, we're trying to capture what went wrong as well as what went right. And when we were doing upgrades, certainly from our PAS, which is so huge, we learned so much from other trusts who told us all of the things that they learned and that charged them with the biggest problem in the workplace. And we were so grateful to them, the honesty that people give. And being able to capture that to turn it into a checklist for when you go live is so important. And the final thing is the scalability. I think sometimes people look at, say you took GS1 as a whole, across the whole pathway in one go deliverable, it's too big and it needs to be broken down, because if you scale things up and you prove proof of concept and you get champions and the trust sees it's a good thing to do, then people opt in and they start to be more involved, and that's how we're tackling it. To do it in small areas, we did it with the observations, we went paper free, we did the same thing, we did it in scalable areas, and we won and we got it right. And that is a lesson for kind of complex organisations, which all of healthcare is, to do it right and then move on. Next slide, please. So for us, we're a very busy and complex organisation, and if things aren't busy enough, we think we might look at doing more things in the workplace. So on the table next year may be a merger with a sister hospital. They're already hopefully a fast follower of ours, so we work closely together. But I guess I see it also as an opportunity to try out blueprints, test beds, learning from our experiences and trying out our blueprints to see if they work. Compliant procurement, that's Sandy's area, it is so important. Maybe Sandy would like to say a few words about that really big challenge.
Yeah, so we're a trust that really tries to be as compliant with all the procurement regulations as ultimately possible to be. Those of us that come from a procurement background understand how difficult that can be, whilst not being an obstacle to day-to-day business delivery within their respective trusts. However, under the GDE, this is a requirement for us. What we've found is obviously there's a distinct lack of quality frameworks that we can call upon, though more and more are coming forward, which is great news. But also how you balance innovation to a compliant procurement process and the implementation appropriately for that. But we've started to work within those constraints, and actually once you take the first step, it's not proven to be as difficult as we thought it might be. A lot of it is down to a lot of hard graft at the front end, which seems to delay progress in the beginning, but actually it saves time later on. We're also finding that, where we've made a kind of an internal mantra that we are only going to deal with GS1 compliant solution providers, that criteria, if you like, is restricting the marketplace for us. But we think it's necessary. There is no point in us engaging with suppliers, many of which haven't even begun the GS1 journey other than talking about it. They haven't even engaged with Juliet and her support team. So that's an issue for us. And I have to say that since I've been more active on the GS1 agenda in the last year, I have seen a huge increase in this, but we're still very much at the bottom of the curve. So that's the key issues from the procurement perspective.
So compatibility, we're part of Interopen. We work really hard with suppliers and other trusts to try and drive down variation to make people GS1 compliant, because it's no good buying solutions that aren't ultimately going to serve us at our end goal. And trying to get that, so we've had to change. We've got a medical equipment group, the purchasing group, and there's been a big drive by me in particular to say you've got to cover the future. And now we look for that when we're going out to procure things. And we ask suppliers, and we're quite hard about it. We won't buy them if they don't meet those needs. But it's still a challenge. There are so many areas where people, especially, equipment suppliers, think they are a law unto themselves. And under WannaCry, they haven't done very much since then. Really disappointed, to be honest. But compatibility is a major challenge, especially if you're best of breed. And then integration. It's so important it works across the whole platform. We've just watched a whole patient journey on the video, and out of that is your BI layer over the top. We want to be able to build up a full picture, patient level costing, quality agenda, knowing we did the right thing at the right time, knowing what drugs we prescribed and by whom, and who gave that order and where it was linked to in the record. So all of that is being built. It's a big ask, but I think it will just be so rewarding, and it's where we've wanted to be for a long time, and it's supporting that vision for us. So we're tying it together. We've got an awful lot of brains looking at it now, and hoping to put that forward also as a how we did it, so we can share that. Next slide, please. So, as I've said, we're doing it in bite-sized chunks, and we're learning. So everything we've done, we've piloted. We go sometimes for our quietest areas. When we were doing EPMA, we went to the elderly care wards. We were there for quite a while. But then we had a really rapid deployment of things going to all the other areas. And so that's how we planned that one. With this one, we're starting with e-pharmacy, and we're looking at kind of EAU level to do our cabinet rollout and our barcoding. Then we'll do an evaluation, and then we will hope to put forward a bid if other funding becomes available. But underpinning this is if there isn't other funding, then as we've heard, it gives us quality wins, it gives us cost effectiveness, value for money. So we've put together a business case in the same way as we do. The most important thing in business cases for anything technology related is proving those benefits were realised. And a lot of those benefits do not sit with getting rid of 3 desktop people. They sit out in the business. They sit in the patient level. And they sit in the effectiveness of our nursing and medical teams being able to do the jobs they were employed for. So it matters that benefits are measured and owned across the pathway, not just inside IT or inside procurement. So we're working very closely with everybody to try and find other avenues for funding, but we are also, well aware that we may need to do some business cases inside. And the Trust have always been very supportive if they know there are real benefits and wins, and having exec sponsorship makes a big difference in terms of the palatability of that. So unfortunately, in a trust with a large technology base, we have to constantly make sure that our revenue and income matches the needs and that we upgrade all of our systems, because if they're not upgraded, they won't be compliant and they won't then provide us the functionality. That's something that we have in terms of an annual plan. It's in our 5-year strategy, and it's all linked back to the deliverability of our vision, which is underpinned with GS1 absolutely at the core of that. And change management, what can I say about that really? I think people always underestimate that it's not that I think we're invisible. I try hard not to be invisible, but I also try hard not to be visible. I am part of a team, I am part of a programme, and the programme is clinically led and owned. And all of the people who deal with patients and who are delivering care are at the forefront of this. They're delivering it, it's their vision. They say to us, right, that system isn't working, or you need to tweak this, or we need a different way of barcoding. The plan is not working. We go away, we tweak, we try, and we come back and we do it again. We've done it with every system we've rolled out. And there are changes in certain areas, not to the fundamental system, but to the way it works, or the hardware we've adopted, or the way it's configured at the bedside. And we make those changes, and then we go back and then we retry it. And it's been working really well for us, and our clinicians are happy to stand up and talk about their journey and their delivery of something, not for IT to have to go to the forefront or for procurement to talk about it. And that really, really matters.
Yeah, just to interject there, we found when GDEs and the GS1 team came and joined us for a joint presentation to the key identified stakeholders back in January, that whilst it was very difficult to even get them there, having exec sponsorship of that presentation helped. But by the end of the 45-minute presentation, we literally had a queue of clinicians wanting to know more about it. And the presentation was very sort of, outline stuff, not dissimilar to what Juliet presented at the beginning of today's session. But as soon as you make it aware that this isn't a threat, this is going to enable them to do the things that they moan about not being able to do because they're doing things that are really outside of, key clinical deliverables. It's amazing the feedback that we got. I'm regularly stopped in the corridor, oh, I need to talk to you about this, and when can we get put on the agenda to be part of the next part of the process? And I think it's the part of the change management has to be about the education is perhaps too strong a word, but making people just aware of what this is, aware of how it can only be a positive. There is, I haven't seen anything negative to come out of this. And once you get that message across, kind of as Philippa said earlier, be aware for the, increased knocks on the front door. And actually, part of my concern is how we're going to cope with the flood of engagement now.
So it's all positive. I mean, the change management is how we adopt everything and how we change things here. And that is we're a team and everything is clinically led. And it makes such a difference because it's for them. And The analytics, when people are talking about, you know, what the patient had and how long it took and what implant, etc., that most clinicians want to know that. They'd like to find it out for themselves first and be able to interrogate it, not be presented with it at the end of a month. So all of those things are positive. I can't see very many negatives, to be honest. And using it for the blood tracking, I mean, it's based on the same principle, has just revolutionised the safety of giving a unit of blood, decrease the number of staff involved in the handoff, and just improve compliance all round. So we have really positive feedback from that, and just more and more adoption of that technology, which is what this is. Next slide, please. So, I mean, I think it is challenging to train anything across the whole trust, and having trained e-notes or training e-pharmacy, and we've done all the hard to go to areas. We're doing A&E at the moment, and we've done maternity, and we never shy away from going to places that others don't. And with all of our contingency areas for e-pharmacy, some places are used for escalation. Every single one of those is compliant with all of our e-tracking, e-pharmacy, e-bed management, e-everything, because it matters. If you're going to be E, you must be E across the whole paradigm. So with training, we have e-learning, we have online portals for people to log in from home, we have set up webinars for people, we go out and do face-to-face in the workplace training, and then we also run conventional training packages too. There isn't one type of training that's right for every single system, and we're hoping to train the whole paradigm soon. So as part of our GDE plan at our innovation centre, we have a desk set up and a bed set up with all the technology there, so we can walk through before people go out into the ward environment. Very positive. Benefits management is really strong here. You have to prove you're going to do what you say you're going to do, and that you delivered what you say you're going to deliver. And it serves you so well later on when it comes to the challenge part, and it keeps everyone on board. Finance look at it from their point of view, clinical teams look at it from their point of view, quality and safety look at it from their point of view. So it needs to talk to a varied audience. And the metrics that we've been using, which we were using already, the Cranfield methodology, has worked really well for us. Recruitment, we are so lucky to have recruited a really brilliant team of people with so many different types of expertise under GDE, but it's paid dividends in terms of doing GS1. Having Sandy has been such a benefit. Procurement teams are usually run ragged with all of just the trust deliverables, and this is a project in its own right. And if we handle it that way, it will then become BAU and be embedded. But while we're in this phase, having a dedicated expert has made such a difference for us. And then we're also looking at apprenticeships so we can build tomorrow's leaders. And the NHS Digital Academy, we have members on that from our clinical forum and from our IT forum, so we can build tomorrow's leaders and make technology something we all think. In the same way, if you think about a clinical deliverable, you think about how can technology support here, but it should be invisible because it is part of your working ethos. My background's radiology. It's all technology driven, but it's the application of that technology to the patient that makes the difference. And that's how we want to think for the future. Next slide, please. So our GDE programme, we were one of the 3.5 years. We are 11 months into that. It's a phased implementation. There is a timeline that will be part of the slides for you to look at. We have goals and milestones for delivering key points. And the particular point that refers to GS1 is our e-pharmacy, but we are hoping to embed it in throughout the whole programme if we can. So we're looking at GDE, but actually we've been breaking it down to the programme, to our HIM score, and how it enables our clinical colleagues to deliver more safer. So we haven't overcomplicated it. It was part of what we already were doing, and we're just enhancing that platform, really. Next slide, please. So there it is. It looks very complicated, but it really isn't. There's the key milestones, but underneath all of that is the journey. And I've done it, so on the wall, where every single element of our patient interaction is captured. It says how that's done, who does it, how we're going to do it in the future, where does GS1 play in, where will the barcode be read, what does that barcode look like, and we're just building up a whole walkthrough. So we could walk anyone through, clinically, operationally, technically, and we all share the same vision. And I think the opportunity that this has afforded us is incredible. And we've looked at every part, so speech recognition, if we can barcode and collect the data in one swoop without keyboard entry, we're absolutely going to do that. Going to do everything to make it safer and more efficient. Next slide, please. So that's the pharmacy. We've just broken that down into milestones with our GS1 elements overlaid on the top, and it will be part of the whole core deliverable program. For e-pharmacy, we have a clinical team. We have a dedicated nurse. We have a dedicated pharmacist. We have dedicated pharmacy technicians, and we have dedicated IT team as well as procurement and project management. But all of that works within the GS1 and GDE team. We have a whole team. They all work together. They're all based in one place, and we deliver it all together. So although we can break things down, it's also part of a bigger deliverable, and that just makes it manageable for us. And the cabinets in there and the compliance milestones are also outlined. So we deliver what we need to, but we keep our eye on the overall arching patient journey. I'm trying to make sure you have time for questions. So I'm not rushing through it, and you can ask me anything you want to, but it's there for you to look at later. Next slide, please. So for us, in summary, GS1 is not a separate part. It's a key deliverable within our larger program. I can't see how we can deliver our compliance and our HINS level 7 and our quality agendas and safety. Sandy had a really wonderful, I was trying to kind of capture it, and we here have been really big supporters of invest to save, but actually Sandy is coming up with a better, so here we go. Your takeaway trademark saying from this is?
We're going to change invest to save to invest to safe, because ultimately it's the patient safety that's got to be the driver behind all this.
So we thought we liked that, wanted to share that. I don't think you can do our GDE without our GS1, and we see it all as part of the same platform. We're learning from others, and we're happy to share everything that we come across. Being a best-of-breed site will make us different to other elements, and there are quite a few sites still out there not doing the whole EPR in one go, and we're trying to align it to all of the other standards. On my large wall, I've also got every single national deliverable. I've also got the Carter drive underneath. I've been mapping it all out to try and comply with as many things as we can in a mandatory way, but also in a patient-facing way, so it fits into the bigger picture. And yeah, it's a mandate for all acute trusts. We want, if GS1 is so full of benefits and it is easy to deliver because others have paved the way, and it isn't such an onerous task to get your board on board, then hopefully it will be something that we can all do and bring the benefits to the whole NHS, which would just be fantastic from a patient safety point of view. And as a clinician myself, I'm just so supportive. So anything you'd like to add?
I think it's just someone has to take the first step, and it might be a very, very tiny step, but everyone must have done that by now. If not, by Friday. Go for it. Set yourself a target and do it by Friday. Make an appointment, speak to one clinician, get it started, get some support behind you, without a doubt.
Eat the elephant in bite-sized chunks. That's what we do with everything, and it works for us. So next slide. I think that's us. I think that's our slides. Yeah. So we're happy as a team, including Juliet and Kate, to take any questions. Just thank you for listening, and that's our journey where we're at now, and we'll keep updating through the blueprinting and the network.
Definitely.
Thank you.
Okay, thank you, Juliet, Philippa and Sandy. That was really informative and insightful presentation. I'm sure it's given everybody lots of ideas, tips and suggestions. We have one question which has been sent in via the chat function, which everybody can use if you want to send another question. So our question is from the CIO at Imperial, Sanjay. He has asked, has DOH provided an ISN for third-party EPR suppliers, e.g. Cerner, to encourage them to be able to consume and manage GS1 standards? Otherwise, implementation will require multiple linked databases, which will not be entirely straightforward. I hope that makes sense.
Yeah, we think that question's probably for Juliet because we've been looking at all of our suppliers. I haven't checked because we don't have Cerner here, although Milton Keynes in our SDP does have Cerner. They may have checked. I think nationally there should be a database, isn't there? So we'll leave that for Juliet.
Okay. I just want to, because I've just had a few people join the room, so I'm going to just welcome a few people if that's right. I've got David Weatherby in here, who's also a GS1 consultant, and I've also got Glenn Hodgson, who is the Head of Healthcare. So we do have an answer to that, and I will hand that over to Glenn to answer.
Thanks, Juliet. Yeah, I mean, that's obviously the critical question about certainly about how data can be, or GS1 can be consumed into systems. It reminds me of a conversation we had with Matthew Swindells back in November, when he specifically encouraged us actually to reach out to the GDEs, and thank you for a brilliant presentation today. And his sort of challenge to him and to his team and to us was how do we make GS1 standards? It is the standard by which we procure future systems by, because it's absolutely crazy if we've got a supplier contract and a provider contract that states that you should that comply with GS1 standards, if actually we're procuring brand new systems that are not encouraged to be so. And I think David has a further comment to that as well.
Just to say that there is an ISP standard, ISP 1077, for the wristband, and that has been mandated now for a number of years. So there is an ISN related to the production of wristbands, which clearly links into patient administration systems.
Does that answer the question?
Okay, thank you very much. So we don't have any more questions. So thank you very much, Juliet, Philippa and Sandy, for your presentation. And our next webinar will be on the 9th of May from Salford about data science programme. Oh, yes, that's it. Thank you everybody for joining us.